So far in this course, you have learned to properly interpret the rhythm strip of an ECG. So this is for you. But to properly diagnose an MI, you will need to go beyond looking solely at a rhythm strip and obtain a 12-lead ECG. This comprehensive readout provides a thorough overview of cardiac activity in 3 specific regions of the heart. Today we'll look at the anterior portion, the inferior portion, and the lateral portion. And as you might imagine, obtaining a clear view of the electrical activity requires precise lead placement. To gain insight into this process, let's delve deeper to better understand the intricacies of lead placement. The leads consist of 3 limb leads, 3 augmented leads, and 6 precordial leads. 6 nodes are strategically positioned at the top of each arm, the upper part of each leg, and on the inner ankle of each leg. The remaining 6 nodes form the chest leads, V1 through V6. The arrangements of the leads produces the following anatomical relationships. Leads 2, 3, and AVF view the inferior surface of the heart. Leads V1 to V4 view the anterior surface. Leads 1, AVL, V5, and V6 view the lateral surface. And leads V1 and AVR look through the right atrium. So why is it so important to view these distinct areas of the heart? Because an MI can occur in any part of the heart, and each location will look differently on the ECG. One way to diagnose an acute MI is to look for elevation of the ST segment. Here we see a normal ST interval, segment, and elevation. Now compare that to elevation of the ST segment. If there is elevation greater than 0.01 millivolts, or 1 small box, present in at least 2 or more leads, it suggests the likelihood of the patient having a myocardial infarction. Furthermore, if the elevation is observed in 2 or more leads among V1 through V4, it indicates a probable anterior wall myocardial infarction. Now it's your turn to put your knowledge to the test. Are you ready? According to this ECG, do you think this person is having an MI? And if so, where? In this instance, there is evident ST segment elevation observed in leads V3 and V4, meeting the diagnostic criteria for an acute anterior wall myocardial infarction. Now that you know where to look for an anterior wall myocardial infarction, let's look at how you would determine if the MI involves the lateral wall or the inferior wall. As we know, the anterior portion of the heart is best viewed using leads V1 through V4. The inferior wall, however, is best viewed through leads 2, 3, and AVF. Therefore, if ST elevation is noted in 2 or more of these leads, as seen here, the MI will have involved the inferior wall. An MI involving the lateral wall is best viewed with leads 1, AVL, V5, and V6. So, according to this ECG, do you think this person is having a myocardial infarction? And if so, where? In this instance, there is evident ST segment elevation observed in leads 1, AVL, V5, and V6, meeting the diagnostic criteria for an acute lateral wall myocardial infarction. Certain myocardial infarctions have the potential to impact multiple regions of the heart simultaneously. Take a moment to analyze this ECG and see if you can tell what areas this MI has affected. If you noticed ST elevations in lead V1 through V4, as well as leads 1, AVL, V5, and V6, you hit the mark and have just diagnosed your first anterolateral wall MI.